Thank you. And thank you, Dr. Eben. That was very elegant. Walked us through those pathways that made my talk a lot easier to follow. These are my disclosures. I just have grant support from GSK for Biologic. So I want you to consider this patient. This is one of my patients. He's 38 years old. He has asthma since he was age 3. He's a never smoker. He said that when I met him the first time, he mentioned that his asthma's really worsened since he was in his 20s. But he never really had much difficulty with his asthma during his childhood and teenage years. And over the last 2 years, he has had several acute exacerbations requiring multiple ED visits and hospitalization. He has daily symptoms. His asthma control test score is 11, indicating poor control, and these are his medications. So he's currently coming to me on an inhaled steroid, a long-acting beta-agonist, a long-acting anticholinergic, a leukotriene modifier. So I think he's got all the groups that we currently have, and he's just now finishing a taper of prednisone for acute asthma. So my question to the group is, does this patient have severe refractory asthma? If you can just show me by show of hands, how many of you feel that he would meet criteria for severe refractory asthma? And would you consider a biologic next for treatment of this patient? Okay. So I want to start from just going over the definition of severe asthma as per the ATS-ERS guidelines, where we would consider asthma to be severe if the patient has had GINA step 4 or 5 of therapy in the past year, or has required systemic corticosteroids for greater than half the previous year, or has remained uncontrolled despite such therapy, or becomes uncontrolled as soon as you try to taper therapy. And the estimated prevalence, as Dr. Riedman had mentioned, is about 5 to 10%. And this is where you would definitely consider add-on therapy, but I would also, I think we can never overemphasize this little circle that you'll see above every GINA stepwise treatment that tells you that we really have to go from that 50% uncontrolled asthma. They can't all be severe. The population, the CDC numbers that suggest uncontrolled asthma, whereas 5 to 10% is where these medications would fit. We just have to make sure we're addressing the adherence, the inhaler review, the comorbidities, the triggers, and so on. And we also have become increasingly aware of the heterogeneity in asthma, and I think this is a very commonly used figure from Dr. Wenzel's paper in Nature Medicine, where we used to try, and this phenotyping of asthma is not new. We've always talked about intrinsic asthma or extrinsic asthma, asthma with fixed airflow obstruction, the Samter's triad. I mean, these are all different phenotypes of asthma. We've just gotten a little bit better in terms of doing more inflammatory phenotyping, where we're now looking to try and see what kind of inflammation they have. Do they have type 2 high or type 2 low inflammation? And then within this type 2 high versus type 2 low inflammation, you have a collection of features that give us some idea about endotyping, which is really the molecular pathways that lead to these phenotypes. And currently available and pipeline biologics really only target half the population, because the eosinophilic or the type 2 low asthma makes up about 40 to 60% of adult onset asthma. And again, we just heard elegantly the different pathways that lead to the type 2 inflammation. And there are several biologics that are currently available. There are three of those that are already available. They're FDA approved and commercially available. The omalizumab that we've had for a long time, and then mepolizumab, rezlizumab, which are both anti-IL-5 antibodies. Mepolizumab is available in a sub-Q form, given 100 milligrams every 4 weeks. Rezlizumab is weight-based IV every 4 weeks. And then these are in the pipeline and with very promising results, including benralizumab, which is the anti-IL-5 receptor, IL-5 receptor blocker. Dupilumab is a IL-4 alpha subunit receptor blocker, and tezepelumab, which is the TSLP. The study just came out in NEJM. But who are the who are the people that we should be considering these biologics? So I'd refer you to the IDEAL study, which was put together by GSK, and they found this was looking at patients who had severe asthma who were not currently on a biologic to see, using the criteria used for eligibility in the clinical trials, who might be eligible. And it looked like about 20% were eligible for mepolizumab. But keep in mind, the eligibility criteria for the study for both for Mensa was absolute eosinophil count of 150 cells per microliter. So the reslizumab, the eligibility criteria was 400, and there were, based on those criteria, not surprisingly, fewer patients would have been eligible for reslizumab, and then about the same amount, 20% for omalizumab. And this table really summarizes what we know about these biologics so far. So there's most of the outcomes have been really exacerbation frequency, and there's good data showing that omalizumab, mepolizumab, reslizumab, all of them seem to impact positively the exacerbation rate. Some also improve lung function when that was an outcome, as well as there are two studies that have shown patients who are oral corticosteroid dependent, one with mepolizumab and one that was just published with benralizumab. They were able to reduce their corticosteroid dose by about 50%. And this has really been the range of exacerbation reduction rate in these patients. And on an average for the first four, it's about 50%. Omalizumab was 25% in the clinical studies, but I'll show you some data where if you look at the real life, more stringent criteria for enrollment, their response is much more robust. And then the last two, dupilumab and tezepelumab, both of which block the pathways in a more upstream location and have more carefully selected patients, seem to have a even more robust response. So this was a surprise with omalizumab when some of the follow-up data became available for real-life experience with Xolair or omalizumab. The outcomes were actually a lot better. And you know, we think that may be because those patients are being more carefully selected. They undergo a full protocol assessment, and also it's hard to get payers to pay for something that expensive until we've shown adherence and we've gone through the whole gamut. Also, I would want to mention mepolizumab when it was first studied was a negative study, and the company actually almost walked away from developing it further until they did some additional analysis and found that if they targeted the eosinophilic phenotype, they have a signal there. So I think this just, again, not to belabor the point, but patient selection really is important. And we have some subgroup data looking at who are the people who respond, and there are certain biomarkers that do predict response in these patients. So in omalizumab experience, it turns out that it's not the IgE actually that predicts response. In fact, it has no correlation with response, but it is more the eosinophilic markers, so both exhaled nitric oxide levels, the absolute eosinophil count, and periostin level, which was a biomarker. It's not commercially available, but was used when anti-IL-13 molecule lebrikizumab was being studied. Another study that was just published further looked at who are the patients based on some of the clinical characteristics and found that, again, elevated blood eosinophil count, a history of emergency asthma treatment, a history of hospitalization, lower FEV1 percent, higher inhaled corticosteroid dose, and use of long-acting beta agonists seem to identify the patients where the response was more robust. And it seems that the response, actually, there is a dose response. The higher the eosinophil count is, you seem to get a more robust response. So when you divide the decrease in exacerbation rate between 200, 300, and 400 cutoff of absolute eosinophil count, you see a dose effect in decrease in exacerbations. And a similar finding was seen with the mepolizumab when they went back and looked at the response based on the absolute eosinophil count. The higher the absolute eosinophil count, there seemed to be a more robust response. Although the cutoff that where you could see the signal was at 150 cells per microliter. Dr. Riebman mentioned the study already. This is the dupilumab data. It's a phase 2b study that was just published by Dr. Wenzel. It's a 12-week-long study with about 770 patients. This was a dose-ranging study, and there was a significant decrease overall in compared to placebo in the exacerbation rate, and there was some improvement in lung function as well. But when you divide it, they seem to be effective in both a cutoff of greater than or less than 300 absolute eosinophil count. And the Q2 weekly dose seemed to be more effective than the Q4 weekly. So they use 300 cells as the cutoff to see, but I'd still like to look at the data to see where things were. Did the patients still respond when they were at 200 or 150 or less than 100? We still don't have that information, and that would be really helpful. The tezepelumab, which blocks in a much higher, much more upstream location, so you're again targeting the redundant pathways. It turns out that was effective, quite effective, and it did not matter if the eosinophil count was greater or less than 250, if the exhaled nitric oxide level was elevated or not. And the Th2 status, which they determined by an IgE level that was less than 100 and an absolute eosinophil count that was less than 140, it was still effective in both Th2 low and high population. So I think, at this point, our recommended strategy would be you get the patients through steps 1, 2, 3, 4 of GINA, try to make sure that they are truly severe refractory by confirming adherence and all the stuff, and then try to phenotype them better. And the biomarkers would be our best guide. Patients who are frequent exacerbators, patients who have high eosinophilic phenotype, those would probably be the most likely to respond to biologics. We have a whole spectrum or a variety. We have the IL-5 and the anti-IgEs available currently, but there are several others that are in development that should become available. Unfortunately, we don't have any other biomarkers other than the IgE and ENO and absolute eosinophil count really to guide therapy. Sputum eosinophilia would be great, but it's really hard to do that outside of a research setting. And I'm hoping we'll see more easily available biomarkers that will be able to guide further. The one thing I wanted to mention that I didn't include, there was another study which I'd refer you to from the STARP data on the exacerbation-prone asthma. And when they looked at the frequent exacerbators, which were people who had more than 3 exacerbations per year, it did correlate with their blood eosinophil. There was, in fact, an inverse correlation with their serum IgE level. But the two things that it correlated most was GERD and rhinosinusitis. So again, comorbidities playing a huge role in causing frequent exacerbations, and we just have to keep that in mind. But again, I agree, it's an exciting time. We're going to have more biologics than we can pronounce or know what to do with. So I'm sure we'll look forward to hearing what Sham has to say. Thank you for your attention.